4 minutes past 2. You're tuned to KSQM 91.5. It is 68 degrees. I'm Sassy Susan, and I am so pleased to have in the booth with me Dr. Adam Killpack from Olympic Medical Center Podiatry. He is a practicing podiatrist providing foot and ankle care, including surgery to patients as part of the Olympic Medical Center Orthopedic team. In addition to performing preventative care and surgery, he treats common issues for feet and ankles, such as bunions, ingrown toenails, and injuries like plantar fasciitis. I think I've had all of those, yes. So welcome, Dr. Killpack. We're so glad that you're here because the title of this is Help, My Feet Hurt.
I'm happy to be here.
If your feet hurt, you're miserable.
That is true.
I speak from experience, yeah. So for all those people that might not be aware, what does a podiatrist do?
It's a good question. The role of a podiatrist has changed throughout the years. Initially, podiatry really was focused almost solely on conservative care, some of the nail care, shoes, inserts, things like that. Over the years, like I said, especially recently, the focus has been really changed to manage the full spectrum of not only foot but ankle pathology. Current or modern day podiatrists all go to a 4-year postgraduate program, very similarly structured to a standard MD or DO school, followed by a 3-year surgical residency. Wow. Where we're trained in various surgical procedures. And also spend time in clinics and working with other specialties. So a modern-day podiatrist, as you kind of alluded to in our intro, we do treat a lot of the common issues such as ingrown toenails, hammer toes, bunions, with a kind of a heavier emphasis on conservative options, orthotics, shoe gear, things like that. But nowadays we are able to treat trauma, both of the foot and ankle. Just like many other professions, podiatrists are starting to even specialize within podiatry, and some go the route of advanced trauma, reconstructive surgery.
Not to the point of I only take care of left feet, or I only
not yet. There are no. All podiatrists generally treat both sides.
Okay, good. Yes. That's nice to know. Yeah.
Yes, that we haven't gotten that niche just yet, but who knows? One day we might.
So I was listening to you with your education requirement. You go to a 4-year degree, and then you have another 4 years for podiatry?
So it's a 4-year undergraduate.
Right.
And then like most, and then we do a 4-year postgraduate program, which is kind of broken up, like I said, like most medical schools where it's 2 years of didactics. There's 9 podiatry programs in the country, and most are associated with like a DO program. So we're sitting side by side with the DO students for all of the basic sciences. During the summer, we do our podiatry-specific courses, and then the second 2 years, we're doing clinical rotations in clinics that are either podiatry or podiatry adjacent, such as wound care, vascular surgery, and things along those lines.
Wow! I did not know that.
Exactly. It has come a long ways, and that's, like I said, we're now having podiatrists that, they are doing, full spectrum foot and ankle care, including total ankle replacements, which is, kind of one of the newer joints that is being replaced.
Well, you think of the numerous ways that an ankle has to move. I mean, it's not just one way back and forth. You got to move sides, and I'm making motions as I'm sitting here. But yeah, you don't appreciate all that an ankle does and the weight that it bears.
Absolutely, not just the ankle, but the whole foot, foot and ankle. It's an amazing, versatile structure that also really gets beat up, and that's why podiatry's here to help out with that.
Well, we're glad that you're here. I'm glad that there's people that do what you do.
Glad to be here.
What is many times young athletes have heel pain. What is the usual cause of something like that?
Yeah, this was a question I wanted to touch on because just recently my daughter, she's 6 years old, started playing soccer, and I was lucky enough to be able to volunteer as the coach. And as the sports seasons start, not just soccer, baseball, football, I will not infrequently see kids that come in with heel pain. And there is a specific condition that can occur in younger children. Normally it's from ages anywhere between 8 to 11. The name for it is called Seaver's apophysitis, but essentially, exactly. Doctors love naming things after themselves.
Oh, of course, yeah.
An apophysis is a fancy way of saying a growth plate.
Okay.
Children have a secondary growth plate in their heel. And what's unique about this growth plate, it's in the back of the heel, is that the Achilles tendon attaches to the top of it, and the plantar fascia, which is a main supporting ligament, attaches to the bottom of it. And so between these two ligaments and just the running and jumping that kids do, this growth plate can get quite irritated. And it can be a source of pain and limitation that can sometimes get kids out of sports. And it can sometimes be a while before they figure out exactly what's going on. But essentially, like I said, one of the most common causes would be this, called Seaver's disease or Seaver's apophysitis, which is inflammation of the growth plate. Treatment can vary as far as how aggressive we need to go. Generally, the first step is looking in getting a gel heel cup. At most pharmacies or grocery stores, you can find some sort of gel heel cup. I'm not sponsored by anyone, but my preferred brand of heel cups is from the company Tuli. I believe it's Tuli. They make some really good heel cups. The idea being we're trying to give extra cushion to that growth plate in the heel. Arch support is also a reasonable option. Like I said, there's the plantar fascial ligament that supports our arch by adding a little extra arch support in the shoe. That can take some of the stress off the ligament and the heel. Once again, a lot of the over-the-counter options, or good old Amazon, type in pediatric orthotics, you can find some options there. And then really stretching the calf. And I tell parents too, trying to rest when appropriate. There's some kids that they go from 2 after-school programs to their club practice to their workout, and really aren't giving their feet time to rest. And I think that can be a big component. But generally, the goal is we're trying to support the foot so the kiddo doesn't have to miss sport or miss practice.
Right.
But in some instances, we do need to try and focus on cross-training. Say, hey, instead of doing the running laps, maybe we're working on upper body stuff or finding activities that aren't stressing the foot out quite as much.
And you mentioned something interesting, stretching. A lot of people don't realize the importance of stretching. They just get up out of their chair and they just take off. And our body isn't really built for that.
Well, that's where there is some controversy in stretching. I personally think that it is something that is beneficial and really can help get ready for activity. And part of the stretching too is really just training the nerves that help control our muscles and tendons. That it's okay to stretch out a little further and not tighten up and put these extra stresses on our joints, or in this case of the kids, the growth plate.
So there is treatment. If you do have a child that is complaining of heel pain, you can get a gel heel cup and rest and just don't overdo it.
Yeah, I think a big part of it is just trying to be smart with our activities. Like I said, if you're really into soccer, maybe don't be doing a whole bunch of extra running around and things like that if you're having pain, and really trying to let things calm down.
Okay, all right.
There are options.
Okay, for those of you just joining us, I have Dr. Adam Killpack in the booth with me. He works with Olympic Medical Center Podiatry, and we are talking about help. My feet hurt. Here's one thing that there was a question: when is bunion surgery indicated? And someone even sent in a question about what can she do to reverse talar bunion. I've never heard of talar bunion, so I'm going to learn something. So first of all, when is bunion surgery indicated?
Well, I think look back up a little bit. Like I said, what is a bunion?
Yeah.
A bunion is kind of an antiquated term. I believe it might be Old English, but I believe it means turnip, because it describes just a red bump on your foot.
We have turnips on our feet?
That's what whoever decided to name it thought it looked like. But essentially, a bunion is a combination of two deformities, if you will. The first is our first metatarsal, which is the long bone behind our big toe. There's normally some instability at the joint that supports that bone. And over time, it starts to drift to the side of their foot and up. And so the bump that we're seeing is actually the head of the first metatarsal just poking out the side of the foot. As the first metatarsal drifts inwards towards the midline of the body, there's tendons and ligaments that are attached to the big toe that tether it the other way. So it's really a combination of the big toe pointing towards the outside of the body and the first metatarsal behind it pointing inward. A tailor's bunion is on the other side of the foot, the fifth metatarsal. It's also might be called a bunionette.
Okay.
I think classically,
a bunionette. It's just a little cute one.
Cute little bunion. I think classically the thought was tailors, as in people who were seamstress or sewers. They would sit with their legs kind of on the side, and the outside of their foot would start to get irritated where that little bump was.
Oh.
Frankly, the cause of a tailor's bunion, they're not as common. And more often than not, they seem to be kind of something that's congenital, but certainly there can be some splaying of the fourth and fifth metatarsals that cause that fifth metatarsal to be prominent. So going to the question is, like, how do I reverse a tailor's bunion? Unfortunately, there's not a lot of info out there, or at least that I'm aware of, that gives us good information on how to reverse either a tailor's bunion or a bunion for that matter. Mm-hmm. It's really difficult to combat the forces that our feet are experiencing. As we were talking about earlier, there's just massive amounts of force going through these ligaments and joints in our feet. And they are, while they're biologic and part of us, ultimately they do have mechanical properties that have limitations and can start to fail. So conservatively, for both a tailor's bunion and a regular bunion, the emphasis is on trying to accommodate. So looking for shoe gear that is wider, maybe going up a half size or size in shoes. There are particular brands that tend to have a wider toe box. Some of the ones I like are Ultras. They're locally available. Yep, we got a pair right here. I'm wearing a pair. It's kind of the unofficial
And this
shoe
was not planned.
Not planned, right?
This was not planned, no.
So Ultras, I think, do a really good job, or sometimes it's just eliminating the shoes that cause pain. And then also supporting the deformities. As far as a tailor's bunion goes, there's not a whole lot to do to support it. With a standard bunion, going back to over-the-counter orthotics or even custom orthotics, there's some thought that can help stabilize the joint and slow down the migration of the first metatarsal. Mm-hmm. So going back to the question of, well, when do I need surgery to fix it? I think first understanding that bunion surgery is not a cosmetic surgery. If the main problem with your bunion or tailor's bunion is the look of it, surgery is not for you.
If you want to wear cute little sandals.
Exactly.
Yeah.
Unfortunately, that's generally not an indication. However, if you are in a situation where you can't find any shoes, even your wide shoes are hurting you, or the toes are rubbing, or the joints hurting, and it's significantly limiting your ability to get around or enjoy life, that's really when we consider surgery. Mm-hmm. For both a tailor's bunion and a regular bunion.
Well, when you were talking about wearing shoes to accommodate your toes, I do diabetes education. We talked before we went on the air, and I've told people that they should wear a pair of shoes that you should be able to play the piano with your toes. You should be able to move your toes around enough so that you could play the piano, so to speak. And too often, I know I'm guilty. Years ago, I would wear little pumps when I was in the Air Force, and my toes would be scrunched in there, and I'm paying the price for it now.
Exactly.
But bunions are not. You have to account. We only have 2 feet, and every time you take a step, all of your body weight is on one of your feet.
In fact, even more than your weight. They've done some pressure gait analysis, and when we're doing the toe-off phase of gait, around 160% our body weight goes through that first, the great toe joint in the forefoot.
Wow.
So, like I said, significant amounts of forces are going through our feet.
And then when you think if you're running, mm-hmm. Oh my gosh. Okay, well, right now I have Dr. Killpack. He's in the booth with me right now. He is from Olympic Medical Center Podiatry. He is a practicing podiatrist providing foot and ankle care, including surgery to patients. What is the difference between some of the commercially marketed bunion procedures?
Yeah, I think that's a really good question, especially nowadays, with all the different social media that's available and their ability to kind of seems to know what we're thinking. There's been quite a few companies that have pushed really hard for marketing their their own either procedures or instrumentation to fix bunions. And as such, it's not uncommon I get calls, or the clinic gets calls, or we get patients coming in asking questions about this procedure or that procedure. Certainly, you go onto their websites, and it seems like all of them are the miracle fix for
It's
for bunions.
magic.
Right? They all
You
are
come
the
and
magic
see
bullet.
us, and your pain will go away.
Right. And so, this is not going to be an extensive or I guess all-encompassing discussion regarding it, but two of the more common ones that I see, and you may have seen them as well on Facebook. I know I certainly, me being a podiatrist, I get advertised to all the time. The first being a procedure called the Lapiplasty is what they marketed. It's by a company called Treese Medical. And the Lapiplasty, it's kind of a play on words from a procedure that's very commonly performed for bunions called a Lapidus bunionectomy, going back to doctors naming procedures and problems after themselves. Dr. Lapidus was discovered that if you fuse the first tarsometatarsal joint, you're able to really straighten things out and provide quite powerful correction for some of these bunion deformities. However, this procedure can be quite technical. As we were discussing earlier, our modern day podiatrist gets 3 years of surgical training. But that wasn't always the case, and some, depending on where you're trained, sometimes you get more exposure to one thing or another. So this particular procedure, while it's the Lapidus bunionectomy, while it's a powerful procedure, it can be technical and challenging to get reproducible results. So this company, Treese Medical, they've developed a system that essentially is a clamp or a jig that will allow the surgeon to kind of more readily reproduce and put the bones where they need to go. And then they have their own special instrumentation or plates to fixate onto the bones. I think, my thoughts on that are essentially that, the procedure in and of itself, while they've kind of packaged and put a nice bow on it, isn't really anything new. So I have had some patients concerned saying, like, I want the Lapiplasty. And, we've had the discussion saying, well, hey, it's not really anything that new. It's something that pretty much, most podiatrists are already doing. There's just different ways to fixate it. So I think with that being said, it is important to understand that these companies often are really going to try and make their product look like it has.
They want to make it look like it's the golden egg.
Exactly.
Yeah.
And like I said, I'm not saying that it. I've had some experience going to labs, and I think they definitely have some interesting ideas. But I think more importantly is understanding and getting to know how comfortable your surgeon is with whatever the procedure is they choose to perform. And I don't think it's a bad idea to, I think it's ever a bad idea to get a second opinion, especially when we're talking about surgery. Another one of the, heavily marketed or kind of really commonplace procedures that has been kind of talked about lately is minimally invasive bunion surgery. Traditionally, we're having to make fairly large incisions so we can expose the bone and make bone cuts and place hardware in. But more recently, there's been an emphasis on trying to do these procedures, but through making smaller incisions and inserting hardware percutaneously or just through the skin. One company that has kind of really pioneered some of this is Stryker. And they are also advertising quite heavily on social media. In fact, I've even seen some cross ads where one company saying, no, ours is better, look, this looks weird, and the other saying, no, this one looks weird, we're better.
Stryker, that's a company that's been around for quite a while.
I misspoke. It's Arthrex, you're right.
Arthrex. I'm going Stryker.
Yeah, Stryker. Okay. Arthrex, but Arthrex is another company that's been around for quite some time and have pioneered quite a few innovations in different surgical fields. The minimally invasive surgery has been something that is a bit more unique, mainly just due to the fact that some of the instrumentation that has come out allows us to perform some of these bone cuts without having to have everything open and retracted and do it in a safer manner. And essentially, instead of making one large incision, we're able to make several smaller incisions, use these specialized instrumentations to make cuts in the bone and shift it over. And then they've also developed these really neat screws and hardware that are very low profile and we can put in percutaneously. And I will say that is something that I have started performing recently. It's new enough that in my training, it wasn't around, but the skills translate. And I've been very pleased with the outcomes. For the traditional lapidus bunionectomy, where we're fusing the joint, traditionally speaking, you have to stay off of your foot for 6 weeks before you can even put weight on it.
Yeah, it's pretty extensive. I've seen people that have had that.
And that, frankly, often is the biggest challenge for the bunion surgery is the recovery. However, we're seeing that through some of these minimally invasive options, just due to the fact that we're not disrupting as much soft tissue, and we have these kind of newer implants that are very robust in their fixation, we're able to allow patients to walk immediately after surgery.
Wow.
And even get them back into shoe gear at around 4 to 6 weeks.
Wow.
Once again, though, it's not a one-size-fits-all, and it really is a matter of making sure that your surgeon is comfortable with whatever procedure they do and that they've had good results. For example, before I actually decided to perform one of these newer minimally invasive options, I went to 3 or 4 courses, spent hours in the lab, really practicing, and had a very frank and open conversation with my patients saying, hey, this is something that I've been training on and doing, but have not yet done it, and explained my expectations. I think it's very important that the lines of communication are clear and everyone's understanding of what the expectations are.
Okay, well, that was very informative. Some of the things that are available for bunion procedures. What about hammer toes? Yes. That's a because we all scrunched our feet up in our younger days. Certainly. We have these little.
It is certainly a very, very common problem. I think there's that question of nature, nurture versus, was it the shoes we wore growing up? Is it just in our genetics? And I think, frankly, it's a little bit of both. If we're kind of splitting hairs here, our toes can do a few different things. Hammer toe is a description of where the proximal knuckle is sitting up, but the tip of the toe is kind of straight. I think it looks like a hammerhead. Like I said, splitting hairs here, you can have a claw toe as well. That's where both of the joints are curled under. Oftentimes people will have pain with the knuckle on top and the tip of their toe, and more on a rare occasion, a mallet toe, where it's just the tip of the toe is curled under. Similar to bunions and bunionettes, the conservative care.
I love the word bunionettes. I think that's so cute.
It is a fun word. Conservative care really focuses on trying to accommodate the toes. I do like your analogy of giving room so you can play the piano, looking for shoes that have a soft upper so they're not rubbing. There's a whole slew of devices that are available if you go to a pharmacy, silicone pads or toe sleeves. Frankly, my favorite thing to help cushion and protect a toe is lamb's wool. You can get it locally. In fact, I think one of the local knitting stores in Port Angeles, I went in there and you can buy it by the half pound and it works great. You can wrap it around the toes and really help cushion.
So you wrap the wool around your toe?
Yeah, so essentially one of the reasons you do that, so with a hammer toe you get a prominence, and that prominence is either going to rub on the adjacent toe or in shoe gear. As it rubs consistently, the skin reacts to that and forms a callus. And in this case, we call it a corn because it's in one little spot. So the idea behind the lamb's wool is you wrap it around the toe and or weave it in between the toes to help cushion and offload those problematic areas. And the nice thing about it is breathable. Some of these other devices, if you put them on, it kind of causes the toes to get sweaty and irritated. And once it's biodegradable, you can kind of throw it away once you're all done. And I don't think we're making a huge impact on the environment with it. But so that's really what, when people come to see me, that's really what our focus is on initially, talking about how can we accommodate the toes and or cushion them. Certainly, though, in some instances, it's just not enough, or people are saying, hey, I can't get down there and wrap my toes or put this thing on my toes. So that's where there are surgical options and then even, in some cases, in-office procedures that can be performed. For example, for the problems involving the tip of the toe, I regularly will perform procedures in the clinic and perform what's called a tenotomy, or essentially we numb up the toe and go underneath and make a very small incision and release the tendon that's causing the tip of the toe to flex down. And that does a really good job at straightening the tip of the toe, but doesn't readily address the prominent knuckle. And frankly, for definitive treatment for the prominent knuckles or the hammer toes, we're looking at surgery, where we're going in and releasing the contracted ligaments and generally removing a portion of the bone to allow the toe to straighten out. Some surgeons will just leave it at that. Some surgeons will put like a screw or a wire across it and allow it to heal. It's not as quite as invasive as, say, the bunion surgery, but it is still surgery. Opens us up to complications and has a recovery we have to deal with. Toes are challenging because they swell for a long time, and it can be a bit of an involved recovery before things are feeling great. So it's not a walk in the park, but is an option if all of the other measures are ineffective.
Okay, so that gives people an idea of what can be done for hammer toes. Right now it's 25 minutes to 3. You're tuned to KSQM 91.5. I have Dr. Killpack in the booth with me right now, practicing podiatrist. We're talking about feet. Nail fungus treatment options. You go to the drugstore, you're going to find so many things on the shelf.
Exactly.
How do you know what to pick? You don't want to pick something that's going to hurt your skin.
Right.
So how do you know?
Well, I think first and foremost, I think it's important to understand that not all nail dystrophy is nail fungus. Nail dystrophy meaning the toenails thickened, discolored, maybe even a little bit brittle. When you look at the studies, they normally quote the number that 50% of nail dystrophy is due to fungus, meaning that there's a good portion of nail dystrophy that is due to other causes. Out here in the Pacific Northwest with the Olympics just right in our backyard, I see a lot of avid hikers, and just going up and down hills in the hiking shoes, your toenails get irritated. That in and of itself can cause the nails to become thickened and fungal. So it is important to know that not all nail dystrophy is fungus. When it comes to treating fungal nails, this is something that I get asked about, daily. It's a very, very common problem. And generally speaking, when we have 1,000,001 options to treat one problem, none of them are a very good option. And especially when it comes to over-the-counter products, they can make kind of any claims they want and not have to back it up. So for better or worse, if you were to say, which of all of the ones in the aisle should I pick, I would probably tell you none of them. It's my opinion that, well, let me justify that for a little bit. The reason being is they're just not effective. I was working with a resident today, and we were kind of having a discussion and looking at some of the studies of some of the more recent medication or topical medications. The most recent, as far as I'm aware, is called Jublia or efinaconazole, and it's been out for maybe 10 years, and it was an antifungal created specifically for nail fungus, whereas some of the others are antifungal drugs that are used for nail fungus but not for that specific purpose. Some of the challenges being it's the nail. It's hard to get lotion or the medication in there, so it has its own special delivery system and all of that. So the study that they used to get this approved, they had patients apply it to their nails for essentially 50 weeks, daily for 50 weeks, so a year. After applying it daily for a year, there was less than 20% of the participants had resolution of the nail dystrophy.
Less than 20%? I wouldn't say that's a high success rate.
I would not. And at least initially when this came out, it was several $100s. I think now I have a patient who orders it from Canada for like $100, so it's not cheap either. So I use that as the gold standard, saying, hey, this is something that was created specifically for this problem. It's FDA approved, and if you use it daily for a year, you're not even looking at a 50% chance of clearing the nail fungus. Furthermore, even if you do clear it, it's not a vaccine, and the same predisposition you had to get the nail fungus in the first place is going to be there, and it can come right back. I've used the analogy of dandelions or blackberries. The nail fungus, it's just everywhere, and it is very recalcitrant and resistant. So topical options, frankly, as far as eradicating the fungus goes, they're really not very effective. I will often recommend patients try applying like a moisturizer or a very potent moisturizer, generally something that contains 40% urea. That can soften the nail, which makes it easier to groom, which frankly is often the biggest challenge. Is people come in, they don't like the way it looks, and it's difficult for them to trim. There are oral antifungals that studies show they're a bit more effective. The numbers I cite always show that there is a 60% chance to have an almost clear nail and a 40% chance to have a clear nail, so a little bit better. That looks like normally it's a pill that you take daily for 3 months. However, it's an antifungal pill that gets processed by your liver, and there is some concern that it can cause liver toxicity. It's rare, but enough of a concern that we check your liver.
If you're the one that it has the problem, it's
exactly
it's problems.
And even more recently, I was doing a little reading. It showed that in very rare cases, it can induce and or exacerbate psoriasis. So that's why I say, hey, we're dealing with a nail here.
Yeah.
Even if it is extremely rare, I don't feel like it's a great option. And once again, nothing guaranteeing it won't come back again. So bottom line is, it's really only a problem if it's a problem. I generally am recommending people focus on keeping the nails groomed. And if they can't manage that on themselves, we've got,
Does it help to soak your feet in anything?
That's certainly where I've seen like vinegar or apple cider vinegar. I have seen that helps soften the nails to a degree. Frankly, even just soaking in water or Epsom salt tends to help soften the keratin that makes up the nails and makes them easier to manage.
Okay.
And I think the most definitive way to treat them, I do occasionally see nails where, it's more than an inch thick, it rubs in shoe gear, and we have the option to perform procedures in clinic where we can essentially permanently remove the toenail. And long term, there's really not much of a downside to not having a toenail.
Oh, yeah. I've seen people that don't have toenail. I mean, they just paint the tip of their toe with nail polish, and you don't know that there's not a nail there.
Hardly notice.
Now we get to the one that is near and dear to my heart. Yes, diabetes foot issues. Between you and me, we could probably talk for hours. Whoops! Let me turn your mic on. Being a person who is interested in diabetes education, I'm going to let you lead off with, how do you treat diabetes foot issues?
Well, like we were talking about before we started, I think you hit the nail on the head, and that's control your diabetes first and foremost. That is really the driving factor for all of these problems that can occur, is uncontrolled or hyperglycemia. When our blood sugar becomes elevated, it starts to have deleterious effects on our arteries, which brings
deleterious. That's the word of the day.
That is the word. Came out of nowhere. It has some very deleterious or negative effects on several different structures in our feet. First and foremost, I think we talk about the arteries that bring the blood flow down. That's gonna kind of play a role in our ability to fight off infection and heal. It has negative effects on the nerves, which I think, frankly, are one of the biggest reason people start having problems, is they develop peripheral neuropathy and lose sensation.
They can't tell that they've got a rock in their shoe or something.
Exactly.
They can't feel it.
It's kind of really the out of sight, out of mind. So the peripheral neuropathy is a driving factor. And the neuropathy, I think a lot of people, they don't realize that the nerves, they do more than just sensation. We've got sensory nerves, which certainly is a big component of the issues that arise with neuropathy. But we also have our autonomic nervous system, which controls the sweat and oil gland production. And as that gets affected, our ability to keep our feet and skin of our feet hydrated goes down, so it can get dry, thickened, crack, which can be a source of a portal of infection. And it also affects the musculature in our feet, and you can develop essentially atrophy of the tiny muscles or the intrinsic muscles in our feet that help stabilize our toes, and that can lead to other deformities, going back to the hammer toes and claw toes, where now we've got the toes pointing in different directions and creating bony prominences that are at risk for developing calluses that can turn into wounds and infection.
Because if you can't feel your feet, it's kind of hard to walk properly. And you can tell when someone doesn't have good sensation because their gait is different.
Absolutely.
So that affects their back, which affects their hips. It's just, it doesn't end.
It really is a kind of a cyclical problem, or it can be. So that's when I'm talking to my patients who are seeing me for preventative foot care, especially for the first time. That's really the emphasis, is we really need to make sure your blood sugar is under good control. The second tenet, as I say, it's prevention and early intervention. Not everybody who has diabetes needs to be seeing me, every other month for me to look at their feet. By and large, the people that I think need to be seen on a more regular basis are those patients that are at higher risk, namely those that have poor blood flow and or poor sensation in their feet. And so it can be very helpful to come in and be evaluated. But what I tell a lot of my patients as well is just knowing where to go if you have a problem. Mm-hmm. Is very, very important, and that's kind of what I'm here today to raise awareness of
something
as well.
as simple as, before you put your shoes on, check and see if there's any foreign objects in them.
Exactly.
Because I've heard horror stories of people walking 18 holes of golf and they take their shoes off and their toes are all bloody because there was a golf ball in the toe of their shoe and they didn't know it.
It's amazing what ends up in your shoes. I had a patient whose grandson thought it'd be a funny prank to put his popsicle stick in Grandpa's shoe. And Grandpa didn't know it was in his shoe for a week or so.
Yeah.
And he ended up with a wound. And
Yeah.
And we need to care. So yes, that's where, as far as actively what do we do? Need to be checking your feet daily, and especially if your sensation is poor. Oftentimes I'll recommend people get a hand mirror or even one of those makeup mirrors that have like a magnification side that you can set on the ground, because it's not always easy to look at the bottom of your foot. But if you can get a little mag mirror, you can look there and really what people say, well, what am I looking for? Of course, any redness or blisters or any open wounds, but really, areas that are calloused over. I had one podiatrist or one of my attendings mentioned that a callus is a cry for help, or essentially that a callus is a place that of the foot that is getting extra pressure.
Your body
or
is
stress.
telling you, I need extra cushioning, so I'm going to
Exactly.
develop a callus to protect myself.
Exactly. So it's keeping an eye on your feet, and then I think it's a good idea to have a plan in place to if something happens, what am I going to do? Who am I going to call? So that's where I sometimes I'll have patients come in and they're like, oh, it's kind of silly that I'm here. I'm not really having any problems, but I think it's great to establish care so you have a place to go if something comes up and you're not waiting to get in and be seen.
How about trimming toenails? Is that something that you see problems with when people have diabetes?
It goes back to, once again, if it's someone who has controlled diabetes, they're essentially no problem with it at all. Where we can run into issues mainly is in those patients that don't have good sensation. So it can be difficult to kind of gauge where they're at, and if they do take a chunk out of their toe, sometimes they don't quite realize it. Normally they see that, but and those with poor blood flow, and that's essentially, that kind of mirrors what insurance is looking for to allow people to come and see me or my colleagues for preventative foot care. Normally there has to be diabetes and neuropathy and peripheral arterial disease. That being said, I have a lot of patients that it's challenging, whether it's the eyesight that's poor, arthritis in the hands, back problems, or combination of all of those to get down to the feet. So it's the patients that meet those criteria that can come and see me on a semi-regular basis. Medicare normally says it has to be at least 60 days between visits. But for my patients that aren't quite there but still are having trouble taking care of their nails, I know here in SQM we have the Shipley Center, and they do offer nail care. I personally don't necessarily have a problem with my patients, once again, who are well controlled, have good blood flow, good circulation, getting their nails done in a nail salon. I do normally recommend they look for an establishment that, one, will autoclave their instruments, so they're coming out in individual packages, not just going into the barber solution. And if they have soaking tubs, they're using individual tub liners to help reduce the chance of infection. Mm-hmm. But that is a big issue where like I said, for a variety of reasons, people can't take care of their nails. And then if you have neuropathy, you may not know that the nail's digging into the skin, or you cut too close and create a wound that can get infected.
Well, now I see on my guide here you have PRICE, and that stands for...
I think that might be a little bit of a carryover from last time.
Oh, okay.
Where we're talking about.
Okay, but if you have an injury on your foot, it's a good idea to keep it elevated.
Yep. Yeah. Exactly. And I think if we're just head weighting into veering off from just diabetes complications in general, if you have a foot or ankle problem, that is kind of the acronym we use for the initial treatment. It's protection, rest, ice, compression, elevation. And I do think as far as relating this to diabetes, protection is a very important part of it. As you had mentioned, wearing shoe gear that's going to be accommodative and not rub on any pressure points. Similarly, for those patients that have diabetes and neuropathy and peripheral arterial disease, or a history of ulcerations and problems, at least Medicare and insurances can vary from company to company, but Medicare generally will pay for a pair of, we call them therapeutic shoes or diabetic shoes, as well as technically accommodative inserts or diabetic inserts that are essentially extra cushion, reduce friction, and reduce pressure. So that is a big component of it. I tell my patients who are in that category, don't go barefoot.
Yeah.
And they'll go, well, can I wear a sock? No, you really need something on your feet. One of the other kind of little tips I will give regarding socks is, you want to make sure that you're wearing socks that generally are white or light colored. As we said, you don't always know.
And tell people why that is the case.
You don't always know if something has happened to your feet, and it can be hard to look at that. So you take off your white sock and look, and if there's any sign of blood or drainage, that's an indication that something's going on there.
Yeah. If you're wearing a black sock and you're having blood on it, you're not going to see that there's something wrong. So with a white sock, that blood shows up much easier.
Exactly. So that's kind of where we go from controlling the diabetes, checking your feet, and I definitely agree, checking your feet and shoes daily, using shoes that adequately accommodate and protect the feet. I think the next on the list would be utilizing a moisturizer. Like I said, it's very common. Just all of us, as we live longer, we lose moisture in the skin, and especially diabetes with neuropathy can cause dry skin that can result in cracking, fissuring. Many companies or moisturizer companies will have specific moisturizers targeted at diabetic feet, and I think those are reasonable options. Normally, as a rule of thumb, say try and keep it from going in between the toes. For calluses that are really thick, I often will recommend people look, once again, for a moisturizer that has 40% urea. Locally, it's not readily available, but if you go on good old Amazon and type in 40% urea, UREA, you get a whole bunch of options. And that has been very helpful for a lot of my patients who are dealing with thick calluses at keeping them soft or reduced.
So there are a lot of things that if you do have diabetes, I think we both agree, you with your podiatry background and me with my love of diabetes care, that if you keep your diabetes if you keep your blood sugar in a healthy range, you don't have to have all of these problems that we're talking about.
Yeah, there's no reason, you need to, have any issues with your feet as long as you're keeping the diabetes under control. And I think just, paying a modicum of attention to your feet and keeping them protected.
Be aware of what's going on. Well, it is 2 minutes to 3, and I think that will wrap it up. We have a sending song for you that we're going to hear, but we thank you very much, Dr. Killpack, for coming. He is a practicing podiatrist providing foot and ankle care at the Olympic Medical Center Orthopedic team. This wellness forum is always held on the second Wednesday of each month at 2 p.m. and is being brought to you as a part of the KSQM FM 91.5 radio station outreach program. The Dungeness Valley Health and Wellness Clinic is one of 35 free clinics in the state of Washington. The clinic is open to the public on Monday and Thursday evenings. The doors open at 4:30 p.m. and no appointments are needed. The SQM Free Clinic is here to serve anyone who has no health insurance or is underfunded by their health insurance policy.